Hi, everyone. My name is Michael Stewart. I am the Director of Education at the OI Foundation, and I am happy to welcome everyone to today's Rare Bone Disease Alliance Scientific Symposium on Osteogenesis Imperfecta. This meeting is chaired by Dr. Eric Orwoll, and we have a full selection of really excellent topics that we're excited to bring to everyone today. Just a couple quick housekeeping announcements before we move on. I want to remind everyone to please mute yourself throughout the duration of today's meeting. We have a bit of a larger group with us today, and we want to make sure that everyone attending can best hear the information being shared. Also, if you have any questions throughout today's session or any questions for specific speakers, please feel welcome to put them into the Zoom chat. We have designated times for Q&A today, and we're going to make sure that we try to answer as many questions as possible. Finally, I want to remind everyone that today's session will be recorded via Zoom, and we will be posting this later through the OI Foundation's YouTube channel and on the Rare Bone on some online resources as well. And please stay tuned for more information on that that we'll announce later. But with that being said, I want to thank everyone again, and I'd like to introduce Dr. Eric Rush, who is the Scientific Chair for the Rare Bone Disease Alliance. Dr. Rush, hello.
Thank you, Michael, and welcome everybody. I just wanted to take a few seconds to welcome all of you and thank all of you for being a part of this, as well as to welcome all of our speakers. As Michael said, we have a really wonderful program for everybody today. I think you will really enjoy it. So on behalf of all the organizations, the patient network organizations that are involved in the Rare Bone Disease Alliance, thank you for coming today. And also we would like to acknowledge the support of Ultragenyx Pharmaceuticals, who is supporting this symposium. Without further ado, I would like to introduce our meeting chair, my colleague, Dr. Eric Orwoll, who I think many of you already know, who is a professor of medicine and endocrinologist at Oregon Health Sciences University. And so, Eric, please take it away.
Eric, thank you very much. And I want to thank Michael and the OIF and the Rare Bone Disease Alliance for organizing and supporting the conference today. As you've heard, we've got 4 really outstanding presentations with broad research and clinical applications. I'll introduce the speakers as we go along. Once again, I want to remind you that each of the talks is 20 minutes. There'll be 5 minutes for questions after each of the talks. And if anyone has questions, please put them into the chat feature of Zoom, and I'll collate them and present them to the presenters. I hope that we'll have time at the end for a broader discussion and any questions that we didn't cover at the end of the presentations. So let me go ahead and introduce the first speaker. Dr. Joan Marini got her MD and PhD degrees at Hopkins, went on to do clinical training at both Hopkins and Georgetown, and then additional clinical genetics training at the NIH. She's now the chief of the section of heritable disorders of bone and extracellular matrix at NICHD, and she leads the NICHD Osteogenesis Imperfecta research team. She and her group have done really pioneering work to identify the genes that are responsible for a number of rare recessive and X-linked forms of OI. She's going to talk to us about the evolution of OI nosology. Dr. Marini.
Well, good afternoon, everyone, and good evening to the night owls in Europe. I'm happy to start this session off by talking about OI Nosology. Nosology is, of course, about classification systems, about organizing the information that we have now based on variables that we choose to inform us for mechanism, to inform us for treatment. And I'll be emphasizing the nosology that I think is the most useful at this time. I'll try to be fair to other viewpoints. In 1979, David Silence formulated the nosology that bears his name. This was a remarkably useful system for a time frame that preceded molecular genetics of human disorders. Based on clinical exams and radiographs, it divided OI into 4 types in order of decreasing severity: the lethal type 2, the progressive deforming type 3, and the moderately severe type 4, and then back to the top for the much milder type 1. Given what we now know about OI, this system was not correct on inheritance or scleral hue, but that was 40 years ago, and it stood the test of time in very many useful ways. In the 1980s, the work of many labs revealed that defects in type 1 collagen, most commonly glycine substitutions, were responsible for the full range of clinical severity of OI. Structural defects in the alpha chains delayed the folding of the helix and resulted in excess post-translational modification, which could be detected as delayed electrophoretic migration of collagen on gels. However, the mildest form of OI, type 1, did not involve structural defects in collagen, but rather involved a non-functional COL1A1 allele caused by either a stop codon or a premature termination codon. So in most cases of type 1 OI, the mild clinical form, the type 1 collagen is structurally normal. It's made in reduced quantity because the cells synthesize half the normal amount of alpha-1 chains, but there are no structural abnormalities. This is a quantitative disorder of collagen. In contrast, types 2, 3, and 4 are caused by structural abnormalities of collagen. Now, because of the variability of outcome at the same residue in many cases, you can't confidently predict the severity of the mutation if you only know the mutation, but you can often venture a good estimate based on the database of known mutations. So here the nosology makes an empiric choice, and the choice is to group patients based on mechanism rather than clinical severity. We reserve type 1 OI for quantitative collagen mutations, no collagen structural mutations. This means that patients who have a structural mutation that leads to very mild OI would be classified as having mild type 4 OI. As the OI crowd knows, type 1 collagen is synthesized as a promolecule with globular pro-extensions at each end, and cleavage of the propeptides is accomplished by specific propeptidase enzymes. Defects in these processing events at either end result in distinct variants of OI. So at the amino end of the collagen helix, failure to process the propeptide results in a combined OI Ehlers-Danlos syndrome. And you have this retention of the propeptide. It interferes with the lateral addition of trimers to the fibril. That leads you to these very thin fibrils, which make the tissue more friable. These patients have rather dramatic joint hyperextensibility of both large and small joints. Their bone fragility can be moderate or severe based on the specific collagen mutation. What about at the other end, at the processing of the C-propeptide? This outcome was quite surprising. Substitutions at any of the 4 residues of the cleavage site lead to a paradoxical condition called high bone mass OI. Their bone mineralization is increased even compared to standard OI bone hypermineralization. Their DEXA scores may be normal or elevated, and the clinical severity, interestingly enough, is generally at the mild to moderate end of the spectrum. As sequencing improved, many investigators were noting that some OI patients did not have collagen mutations. And in 2005, 2006, there was a remarkable conjunction of patient data, mouse data, and biochemical data that led to a dramatic transformation of OI research. It transformed OI from a collagen disorder to a collagen-related condition. And these discoveries generated a lot of excitement, not just in the rare bone research community, but in the larger bone and scientific research community, because often the importance of that gene and that protein to bone development had not been previously appreciated. And now, of course, with all these new genes and this new knowledge, there was a need for a new nosology for our new understanding. Several different OI nosology have been proposed. Two of these place an emphasis on phenotype and then fold in the genetics, essentially adding genes to the original Solens types. The genetic classification and the OMIM classification place their emphasis on the gene defect and then describe the range of phenotypes. I'll be primarily emphasizing the genetic classification, no surprise to most of you, and then I'll give you my thoughts on why I favor this approach. So this table summarizes the genetic nosology. The 4 Solens types are reserved for collagen mutations, and then new type numbers were assigned as genes were identified and OI typical clinical characteristics were verified. The inheritance pattern is predominantly recessive. There are 2 dominant, type 5 and type 15, and 1 X-linked, type 18. This is not, as some have stated, a random list of genes. Types with similar mechanism were mostly identified very close in time to each other because they might be caused by components of the same complex, or they might function in the same pathway. And this makes them easier to remember, of course. So there are groups that pertain to mineralization and collagen modification and collagen processing and cross-linking and to osteoblast differentiation. Let's start with the 3 recessive types that impair the prolyl 3 hydroxylation of type 1 collagen, types 7, 8, and 9. These 3 types are easy to remember because the proteins interact with each other. P3H1, CRTAP, and cyclophilin B form a complex in the ER that catalyzes the 3 hydroxylation of a single residue on the alpha-1 chain, proline 986. In addition to that, prolyl 3 hydroxylase 1 and CRTAP form a mutually protective dyad. So as you can see up here on the gel, if you're missing one of these proteins, you're missing both of them. That dyad also functions as a collagen folding chaperone. In its absence, collagen folding is slowed down and there's over-modification of the helix, looking biochemically very similar to what you would see with a collagen structural defect. Absence of the chaperone is more detrimental than absence of 3-hydroxylation. That's been shown in mouse models. In fact, no human, to my knowledge, has been identified with a mutation at the proline 986 site. All of these cases are very severe. Many of them are lethal. Lack of cyclophilin B, the 3rd member of the complex, does not destabilize the CRTAP P3H1 dyad, but cyclophilin B also has independent functions. It's the major PPiase of the collagen alpha chains. It's also the foldase for lysyl hydroxylase 1. So if you're missing cyclophilin B, then you're going to experience underhydroxylation, and that differentially affects the lysine 87 residue, which is critical for cross-linking. Types 5 and 6 OI have unique mineralization defects. If you're wondering about my switch in the order, the genes for 5 and 6 were identified after the genes for 7, 8, and 9, but they had been first delineated based on their distinct histology. Type 5 OI is unusual in 2 ways. It has dominant inheritance, like the collagen structural defects. And second, all of the affected individuals have the same mutation, a recurrent defect at the 5' end of a molecule called IFIDM5 or BRIL. It adds a new start codon to BRIL, and it results in a gain of function mechanism. It's generally moderately severe. Affected individuals have this dense metaphyseal band in the forearm and a combination of hyperplastic callus, ossification of the intraosseous membrane, and radial head dislocation. Under polarized light, you see this mesh-like pattern. Type 6 OI is caused by null mutations in pigment epithelium-derived factor, or PEDF. It has recessive inheritance. It's generally not diagnosed in the first year of life, and thereafter is severe and progressive deforming. Affected individuals usually have a substantial increase in alkaline phosphatase in childhood, over 1,000, and their histology is distinctive for broad osteoid seams and this so-called fish scale pattern under polarized light. An interesting connection between types 5 and 6 was revealed by now about a dozen cases with the same mutation. They share type 6-like clinical features, alkaline phosphatase elevation, bone histology, as you can see, and cellular lack of PEDF secretion, but their mutation is not in PEDF, but in IFID-M5. So this graphic shows you these types at a cellular level. Here's type 5 OI with its new start codon properly localized at the plasma membrane. Here's Brill with the mutation that makes you look like type 6 OI. It's stuck in the Golgi because the substitution at serine 40 interferes with palmitylation of the protein. PEDF is encoded by SERPINF1. It's then secreted from the cell. Was known way before it was known for OI as a potent anti-angiogenic molecule. Say that 5 times. It binds to discrete sites on type 1 collagen. And in fact, binding to type 1 collagen is necessary to PEDF to activate its anti-angiogenic properties. What we don't yet understand is how Brill and Serpin are related, but it's quite clear that they are. From collagen modification and bone mineralization, we move to the next category, collagen processing and cross-linking. Here types 10, 11, and 13. These are very rare types, except for FKBP10 is a bit more prevalent. Once again, we find that these are components of a protein complex with similar function. So HSP47, an ER localized collagen-specific chaperone, important for collagen folding. This is so important that even hypomorphic absence of HSP47 leads to collagen so badly misfolded that it results in death in early childhood. FKBP65, encoded by FKBP10, binds to both collagen and elastin. Null mutations in FKBP10 lead to a progressive deforming condition called type 11. So it turned out that type 11 was allelic with a condition called Brooks syndrome, which had been delineated based on being phenotypically distinct originally with bone fragility and contractures. And we now understand that congenital contractures are a consistent variable feature of type 11 OI and can occur or not, even in siblings with the same mutation. And here you see lysyl hydroxylase 2. It's encoded by PLOD2. It's the key hydroxylase for lysine residues outside of the collagen helix, in other words, in the telopeptides. And here you see lysyl hydroxylase 2 modifying residues in the telopeptide. These are critical for cross-linking and for the mechanical strength of connective tissue. And the last gene in this set is BMP1. BMP1 is the protease that processes the C-propeptide cleavage site. I previously told you about high bone mass OI. That's caused by defects in the cleavage site itself. Type 13 is caused by absence of the enzyme that does the cleavage. It results in a very severe phenotypic clinical condition, in contrast to the mild HBM-OI. And that's because BMP1 has a lot of assignments. It's not just cleaving type 1 collagen, it's cleaving a bunch of procollagens and a group of proteoglycans. So to be missing this is to be in trouble. Next up, we have a group of genes that relate to collagen mostly in terms of its production by osteoblasts, but also affects cellular differentiation in a way that produces common OI bone tissue findings. This set includes SP7 and WNT1. SP7 or Osterix is a major factor in osteoblast differentiation, but only 1 or 2 cases have been described, and we don't yet have enough information on the bone tissue. WNT1 is a cause of severe and progressive type 15 OI synthesized by osteoblasts. It binds to frizzled and LRP5/6, but multiple proteins in this pathway lead to dramatically different bone phenotypes that would be the subject of their own talk. Next up, we have one dear to my heart. MSTP S2 is the only X-linked form, and CREB3 1, which is recessively inherited. S2P is moderate to severe, while type 16 has been lethal or severe. What a surprise this was. When S2P processing defects turned out to cause OI. S1P and S2P are Golgi transmembrane proteases that are components of a process called RIP, regulated intramembrane proteolysis. They've been studied up the wazoo for their role in collagen, in cholesterol metabolism. In fact, they were featured in a Nobel Prize. So that select mutations in one region of S2P would cause a bone dysplasia was utterly novel. And in fact, now we know that some defects in S1P seem to cause something that looks like a chondrodystrophy. So this pathway has much more to reveal. One of the metabolic factors that's sequentially processed by S1P and S2P is a protein, transmembrane protein called OASIS. So after being processed by S1 and S2P, it migrates into the nucleus and acts as a transcription factor where it affects both bone vascularization and bone matrix formation. And just a few words on an oddball type, I have to say, TMEM38B, first reported as a null founder mutation among Bedouins in Saudi Arabia and Israel. Its severity is similar to type 4, but there's striking phenotypic variability in families. It's a cation channel in the ER that secondarily disturbs the flux of calcium between the ER and the cytoplasm. Well, of course, calcium is a critical cofactor for many of the modifying and processing enzymes involved in collagen production. So type 14 has the unusual feature of having under-modified collagen, not having high turnover histology, and not having bone tissue hypermineralization. There have been a number of candidate genes that have been proposed as causes of recessive OI. Let me just focus on 2 that I find most appealing. The KDEL receptor facilitates the recovery to the ER of a number of proteins we already know are involved in OI pathology. It has a clear impact on collagen secretion and fibrils. Sex16B is kind of brand spanking new. It was presented at the International OI meeting in Sheffield in the fall and has now come online in EMBO molecular medicine. Here we have a collagen trafficking defect. Bone histology and mineralization are substantially in line with prior OI types, including elevated bone mineralization. I'm almost done. I did promise some thoughts on the phenotypic-based OI nosology. Undoubtedly, there are some people in the audience who are proponents of this. In this system, individuals with non-collagen mutations are merged into a kind of severity score for the Silence classification. The update for this has been published in February in Journal of American Medical Genetics, I think. I find this plan confusing. I think patients and professionals will too. In this plan, the same gene is now in multiple types. Family members with different severity will have different types. The same individual may well have a change in type during their lifetime. The same type can have variable inheritance. I have no objection. In fact, I think it would be useful to have a notation on the nosology on a classification for severity to be useful for physical medicine, for orthopedics, for accommodation at school and at work. I think the genetics, of course, should be front-loaded and the severity notation should come second. The phenotypic classifications front-load the phenotype and add the genetics. So I'm back to where I started. Nosology is a moving target. It's not a scientific fact. It's not a clinical fact. It's an organization of what we know to help us learn more. I think that what we need to understand now is mechanism. What we need to understand now is modifying factors and response to treatments. And I think that this kind of separation by pathway is the best way to do it. Thank you for your attention.
Joan, thank you. That was really clear and helpful, I think. I have a couple of questions for you. Let me encourage other people to use the chat function for additional questions. My first question is, you made a compelling argument for the genetic classification and told us about its advantages. What do you think its disadvantages are?
One disadvantage is that you don't know. Some people say it's too complex. Who's going to learn 20 types? It will confuse the patients. You don't know about the severity when you say the type, because all of them have some variability of expression. And those things are true. And I think another, already we're, as we add the stragglers of the genes, maybe it's time for a conference in which you lock 20 of us in a room and we, we slog it out, because there are things that, if, the Ehlers-Danlos field has had in the time we've been making these discoveries, the Ehlers-Danlos field has had, I don't know, 2 or 3 conferences that have focused on classification. And each time what they've done is say, okay, what do we know now? Let's take a de novo approach. And we know a lot more now. And even I would change some things about the genetic classification if I could, now that we know the groups. So I think, it is a bit cumbersome, but I think it makes the, I'm a splitter, obviously, but I think it makes the distinctions that are necessary for the best research. Okay.
I've got a couple of questions and about 1 minute to cover them.
Okay.
I think you said a little bit about this, but summarize, how many genetic types are there right now? And are there some that are hanging out there and not yet published?
The Sex16B was the only one I knew about that was hanging out, and it had been presented but not published. I think those of us who have been hunting for genes most of us have pretty much solved everything in our freezers. And there are still a few out there, I think, but they'll be really, they almost have to be quite rare unless there's going to be some gene that somebody finds that we all go back to our freezer and everybody says, oh, that was my last 3, that was my last 5. I stopped at 18. There are probably 20 some. I think there's been a tendency of OMIM in assigning numbers to assign at the first report and not wait to see if the condition filled all the criteria of OI. So there's a risk that some things that are fragility that the x-rays look like OI, but maybe lack OI characteristics in other ways. So we might well do with a examination of the classification in that sense.
Okay, we've got a number of other questions that we'll have to save to the end.
Okay.
Joan, thank you again very much. If you could exit, yeah, perfect. Let me go on to the next talk, which is by Dr. Jason Lim. Dr. Lim got his PhD in molecular cell biology at Washington University, and then did a postdoc at Baylor University with Brendan Lee. He's now in the Department of Biological Sciences at the University of Delaware with a joint appointment in biomedical engineering. And Dr. Lim is going to talk to us about the use of mouse models in OI. Dr. Lim.
I'm sorry, I have to unmute myself before I begin. Can you see the slides okay?
Yep, looks good.
Okay, great. Well, thank you again, Dr. Orwoll and the organizing committee for giving me this opportunity to present. And I want to say that in the interest of time, we'll be covering a few mouse models, and this is by no means all encompassing, and there's a lot of work in this field. And so hopefully I give you a glimpse of what's available, and this will interest you to look for more details. So I wanted to start off by stating kind of the obvious of what are the advantages of using animal models in investigating the pathophysiology of OI. And one of the most obvious ones is that it allows us to provide a functional validations of the causative mutations that are presumptive for osteogenesis imperfecta. And specifically, we can use animal models to study tissue-specific defects, specifically by assessing their histopathological abnormalities, their molecular, and as well as biochemical alterations. And obviously, we can find correlations with human patient studies as well. Another advantage of using animal models is this allows us to track the natural history of disease, something that we may not necessarily have the opportunity to do so, particularly with human patients. And this can provide us with better information on how to prevent or delay the progression of disease. And finally, along these lines, we can use these models to test the safety and efficacy of disease-modifying therapies, and I'll briefly touch upon that towards the end of the talk. For those of you who are not familiar with generating animal models, just a couple of brief overviews on how we would go about generating them. So the types of animals that we could generate and are able to generate are either global or conditional knockout animals, conditional being essentially tissue-specific deletion or overexpression of certain genes that we are interested in. And these are more generally used, more generally adopt Krelok-P technology. We can also overexpress certain genes using transgenic approaches or knock-in, which is essentially utilizing the endogenous locus of a gene. And to this end, more recently, we have used CRISPR-Cas9 approaches to create or recreate the point mutations that are essentially identical to the human mutation. And once these animals are generated, we can go on to perform multiple arrays of analyses, not necessarily limited to these approaches, but more commonly, we can perform micro-CT and radiography to examine bone mineral density and bone volume. We can perform histology as well as electron microscopy to look at ultrastructure, molecular analysis using bulk or single cell RNA sequencing, and also, since this is largely, we're focusing on skeletal dysplasias, among other aspects of the disease, biomechanical testing. And so, as Dr. Marini had very eloquently discussed, there are various mechanisms of OI in which we can categorize the etiology, and these are just very broad overviews of what are required for collagen synthesis, and also components that can be aberrantly regulated, leading to OI. And of course, these are some of the genes that Dr. Marini had discussed. And so first off, in terms of looking at mouse models, which I'll be focusing on mostly throughout the talk, is the COL1A1 and COL1A2 models. And this is not all encompassing, but just to give you a snapshot overview of the types of animal models that are available, either due to loss of function in COL1A1 or COL1A2 here below. And I think one of the things that are really great about these animal models is that they represent various aspects of the severity of the disease. This is not necessarily to say that they're exactly identical, but to show that we do have some representation of the clinical features. And so not to really get into the actual details of the nomenclature and so forth, but in terms of mild to moderate phenotypic manifestations, we can generally consider these animal models to display reduced bone mass as well as defects in biomechanical properties. When we begin to look at more severe animals, as you can see here, including the JRT, the brittle mice, the AGA2, and the OIM, which has been studied quite extensively, we begin to see spontaneous fractures to different proportions. And finally, to the far right, you can see some models that also display either embryonic or perinatal lethality. So these are very useful. And I'd just like to briefly go over two of these models. One is the G610C COL1A2 model. And this particular gene variant was initially identified in the old Order Amish community, which is not too far from here in Lancaster, Pennsylvania. We know that through several studies have shown that in both male and females, and these are micro-CT performed at either 10 or 16 weeks of age, that you can see significant reductions in trabecular bone volume in both male and female. And note that it's important to examine the different sexes because you may find that the baseline bone volume is quite different in male and female, depending on the age. In this study, they've also shown 4-point bending to show biomechanical parameters, and you can see that in the wild-type littermate controls, shown in blue, the amount of force that's necessary to displace, in other words, break these bones is much less in the COL1A2 G610C mutant situation. You also require much less strain, indicating that the bones of these mutant mice are much more brittle, again, which is very consistent with what we find in the clinic. Now, the AGA2 model is slightly different in that they exhibit quite severe to lethal phenotypes. And what that means is that in this case, the AGA2 heterozygous animals have variable severity, some of which are lethal, as you can see in the whole body photograph. And when you look at the skeletal staining of these animals, you can see that the bones are abnormal to varying degrees. By micro-CT, you can see significant reductions in bone trabecular bone mass, as well as reduced cortical thickness. As I alluded to earlier, these animals do display, in, I believe, approximately 30% of cases, fracture events, as you can see in this radiograph. Now, one of the interesting facts about the AGA2 model is that when you look at their ultrastructure using electron microscopy, the endoplasmic reticulum of the osteoblast found in AGA2 animals are severely dilated, which is a typical hallmark of endoplasmic reticulum stress, which could be due to multiple causes, including abnormally folded proteins. And so in doing so, the cell elicits the unfolded protein response, some of which can be measured by the expression, the increased expression of downstream target genes, including GAD153, also known as CHOP or DDIT3. And this, and consistent with this observation, these animals also display increased programmed cell death as measured by tunnel staining, and increased caspase-3 expression, indicating that indeed ER stress is potentially a mechanism for causing the bone phenotypes. And work from Dr. Deb Krakow's lab has shown that, and others have shown that attenuating ER stress can have potentially therapeutic benefits. Although in the interest of time, I'll move on to other models for now. So in addition to the colon A1 and colon A2 models, we also have a lot of models which represents the recessive forms, the various recessive forms of OI. And I'll briefly talk about a few examples representing factors that regulate post-translational modification and cross-linking, and those that regulate osteoblast differentiation. So Wnt1 was quite unique in that these loss of function mutations from the two families resulted in early onset osteoporosis and osteogenesis imperfecta. In cell culture, when mutant forms of Wnt1 are expressed, you have significantly reduced bone mineralization, as represented by the lack of alizarin red staining. But this came as a surprise because Wnt1 is a marker for neural crest development, and frequently you would associate Wnt1 or abnormal Wnt1 expression with abnormalities in the craniofacial region. But this study showed that indeed, with lineage tracing Wnt1-Cre lineage cells using the ROSA 26 MTMG reporter, that there are indeed Wnt1 expressing cells. The caveat here is that the Wnt1-Cre is a transgenic line, but this shows that there are some population of osteocytes which are labeled green here, which express Wnt1. And by RNA-seq, there are not much, but small levels of Wnt1 expression in bone. And to this end, the sway mouse model, which is a spontaneous loss of function model for Wnt1, did show spontaneous fractures, as you can see here, reduced bone, trabecular bone mass, as well as reduced cortical thickness. Now, it was kind of assumed for a long time that this was the swaying phenotype of these animals were primarily due to defects in neuronal abnormalities. And this does not necessarily completely rule out that possibility, but when Wnt1 was deleted specifically in osteoblast lineage cells using the DMP1-Cre model, they were phenotypically quite similar compared to the sway model, and also showing reduced bone formation rate, indicating defects in osteoblast activity. And in both of these models, they were able to see about a 90% fracture rate, indicating that indeed osteoblast lineage Wnt1 deletion is contributing to the skeletal phenotypes. Now, as Dr. Marini mentioned, the CRTAP discovery of CRTAP as a contributing factor to OI was obviously quite revolutionary, and this is the mouse model showing that CRTAP is indeed expressed in the on-logga of the cartilage template during bone development in embryogenesis, as shown by fish. And the CRTAP knockout mouse model showed significantly reduced bone mass, as shown here by X-ray, micro-CT analysis, as well as von Costa staining here, indicating lower bone mass in the vertebrae as well. And this was correlated with a reduction in osteoid synthesis, as well as decreased osteoblast function, indicated by a poor mineral apposition rate. Now, So far, we've really talked about the skeletal phenotype, but obviously both in patients and in mice, we're able to observe quite a few extraskeletal abnormalities in OI mouse models. And this is not all, but just some of the phenotypes that we see, including scoliosis, pulmonary defects, as well as decreased muscle strength, which Dr. Phillips will discuss later in more detail today. But I'd like to focus briefly on the joint laxity and restriction phenotypes that are observed both in patients and some of the recent models that we've developed to show in mice. And in fact, there were some studies showing that there were correlations between defects in tendon and ligament injuries in patients with osteogenesis imperfecta as early as in the early 1990s, which seems quite a long time ago now. But even with the CRTAP mouse model, which we later visited, and this is work from Dr. Matt Grohl, who's now at Western University. So he showed that by micro-CT, CRTAP knockout mouse have indeed a significant reduction in tendon volume, as shown by micro-CT here, pseudo-colored in blue. And to the right, you can see the quantification. And interestingly, this was associated with a significant increase in post-translational modification in both 1 and 4 months of age. This is just showing the patellar tendon, but they were able to see across the board in all tendons an increase in hydroxyproline levels, which is consistent with what we see in the bones of these animals, consistent with overmodification. Now, this was associated with abnormalities in locomotor function, including a decrease in latency to fall, also reductions in grip strength, which could also be associated with reduced muscle function. And directly looking at the biomechanical parameters of the tendon itself, they're able to show reduced biomechanical properties in the tendons of the CRTAP null animals. Some of the work that I've been involved in was to look at tendon-specific functions of FKBP10, which, as you heard earlier, is important for post-translational modification as well as cross-linking. And so these models, they're born normally, but develop these contracture-like phenotypes, specifically in their hind feet, as you can see in this image. And when we look at this even in more detail using micro-CT, you're able to see basically displacement of the calcaneus and the rest of the skeletal foot elements. And this is progressively worsening over time, as in this aged model, you can see increased heterotopic ossification surrounding the abnormal joints of the FKBP10 mutants. And when we look at the natural history of this progression, you can see that as early as 45 days of age, in cross sections of the feet, you can begin to see abnormal chondrogenesis. And this is a very localized effect where we see deposition of proteoglycans in the ligaments, where you should normally see type 1 collagen. And this was associated with abnormalities in movement and locomotor function. And this is an example of the open field assessment that we performed, which shows reductions in vertical activity as well as total distance traveled, although the overall movement time remained the same. And we also showed that by gait analysis, there is a significant impairment, particularly with contact of the hind feet in these animal models, and this is quantified below. So I want to switch gears briefly for the last 5 minutes or so to talk about therapeutic approaches. And obviously, the mainstay of treating skeletal abnormalities is through anti-resorptive therapies, specifically by treating bisphosphonates, and also different types of anabolic therapies, including teriparatide and what's described here through anti-sclerostin antibody, which obviously leads to increased Wnt signaling, which is an important component of bone formation. So in the Wnt sway model, which I discussed earlier, anti-sclerostin antibody does have a mild but significant effect in rescuing bone volume as well as cortical thickness in the long bones. They have more of a greater effect in the vertebrae, as you can see here to the right. And this led to significant restoration of osteoblast activity as well as biomechanical strength. And importantly, this led to the restoration of the fracture rate, which decreased significantly upon treatment with anti-sclerostin antibody. Now, we can also use this treatment to treat collagen 1 type mutations, specifically in the G610C model, and you can see how anti-sclerostin antibody treatment was able to significantly increase bone formation in this model. And you can also notice that obviously in the wild type, anti-sclerostin antibody has an anabolic effect as well. Now, interestingly, we can also think about and consider combinatorial therapies. And in this case, these animals were treated either with sclerostin antibody or bisphosphonates, i.e. zoledronic acid alone. But combinatorial treatment seemed to have a much greater effect in terms of restoring bone mass, and this is probably even greater than what we see in saline-treated wild-type control. And so this is obviously an advantage of using and designing different therapies to test using various mouse models of OI. Now, one of the interesting aspects of what we learned from OI models is that TGF-beta and other matrix proteins, which are abundant in the extracellular matrix, can be dysregulated in these animal models. And this is one such pathway. So TGF-beta signaling is activated by binding of the type 1 and type 2 receptors to the ligands, which activates a kinase cascade, which depends on SMAD proteins to regulate gene expression. And so it was noticed quite a few years ago now that TGF-beta signaling through SMADs were abnormally increased in mouse models of OI, including the CR-TAP model. So here you're just looking at TGF-beta reporter activity as well as phosphosMAD2, which are indicative of increased TGF-beta signaling. And we can also see this in situ by immunostaining of the lungs of the CR-TAP, which also have fibrosis. And inhibition of TGF-beta ligands using the neutralizing antibody 1D11 can significantly restore various bone parameters, as you can see here. And importantly, these phenotypes were also observed in the COL1A2 G610C mouse model. Notably, in the severe COL1A1 JRT heterozygous model, which I did not discuss here, this response was not observed, potentially due to a dosing effect or the lack of sufficient 1D11 dose. Alternatively, we could consider that depending on the severity, this drug may have differential effect, and this is something that we need to consider moving forward.
Jason, we've got about 1 minute left.
Yes, almost done. Last slide. Why is this all meaningful? So in terms of looking at abnormal dysregulated TGF-beta signaling in recent work from Dr. Brendan Lee's lab, they were able to show that in patients, there was an abundant representation of increased TGF-beta signaling components. And this is also the case in the biopsy samples of the OI type 3 patients where phosphosMAD2 staining was significantly abundant compared to healthy controls. And importantly, clinical trials showing that anti-TGF-beta therapy has therapeutic value in terms of preserving aerial bone mineral density, as you can see here, are all indications that these types of studies do benefit in the clinic. So just to summarize, I hope I told you a little bit about the animal models that we use. I did not cover zebrafish as well as canine models, which are obviously very important, and they are powerful tools to investigate both whole body and tissue-specific pathophysiology of OI. And importantly, that these mice display a wide range of severities, and that they recapitulate various aspects of the human OI pathophysiology. And moving forward, consistent with what Dr. Marini had alluded to earlier, that we need to further investigate molecular mechanisms that contribute to OI pathophysiology, which can be done using these models. And we need to look more carefully at the effect of therapies with regards to varying severities, as well as its effect on both skeletal and extraskeletal tissues. So with that, I just wanted to leave some of the references that I've covered earlier, just in case you wanted to revisit them. And with that, I'd be happy to take any questions.
Ethan, thank you very much. Another very clear, complete presentation. We unfortunately don't have time for questions at this point. We might be able to get back to some at the end of the program, and potentially Jason can address some questions in the chat.
Yes.
But want to move on to the next presentation by Jennifer Zieba. Dr. Zieba received her PhD in human genetics at UCLA with Deb Krakow, and then a postdoctoral fellowship at Baylor with Brendan Lee, and moved back to UCLA, where she's again with Dr. Krakow's group. She's the recipient of a Stephen Katz Award from NIAMS and a Guzman Fellowship from the OIF. She's going to talk to us about the origins of growth impairment in patients with OI. Dr. Zieba.
Thank you for that introduction and the opportunity to speak today. So just before I begin, I'll be going over some earlier studies concerning short stature in OI patients, and then kind of building off of Dr. Lim's presentation, I'll go into some of the mouse work done on short stature. And as Dr. Lim also prefaced, with the previous studies I'll discuss today, it's by no means comprehensive. I tried to keep things simple. And then finally, I'll end with some of the latest data coming out of our lab here at UCLA. So osteogenesis imperfecta, or OI, it's one of the most common musculoskeletal dysplasias, and Dr. Marini and Dr. Lim introduced it perfectly. Different OI phenotypes are generally categorized into types somewhat based on their severity or genetics, as Dr. Marini went over. And it's also highly genetically heterogeneous, as we already have seen. But growth deficiency is actually a hallmark of osteogenesis imperfecta, and there are various reasons for this, including spinal and bone deformities, but also shortened long bones. And the molecular pathology behind this short stature in OI is unclear. So growth deficiencies in OI have been observed for decades, starting with one of the first publications as a letter to the editor from a group at Northwestern University in 1978 in the Journal of the American Medical Association. And this mentioned intrauterine growth retardation for severe forms of OI, and here it was named osteogenesis imperfecta congenita, and not osteogenesis imperfecta tarda, which refers to milder forms of OI. Later on, additional studies completed at the NIH showed decreased average postnatal growth rates in type 3 and type 4 OI, with no obvious difference in type 1 OI. Skipping to more recent studies completed by the Brittle Bone Disorders Consortium and the OI group at NICHD, they used larger cohorts and followed patients for longer periods. We still see growth retardation in more severe and moderate OI types, like types 3 and 4, and not so much in mild OI. And we can see those same growth curves here in types 3 and 4 for males and females. Although in mild OI, we do see, at least in females from this study, a little bit of a growth, slower growth. But the purpose of these studies are to establish growth curves for the medical community. And of course, larger cohorts like these are very difficult to assemble, as we know. But many of these studies don't specify the specific reason behind each patient's observed short stature. So some studies, however, give us a little more insight into what may be happening specifically to long bones and whether OI mutations affect endochondral bone growth in general, such as this one from 1999 done by a group in Denmark that not only shows overall shortened stature in both mild and moderate forms of OI, but also takes into account spinal issues by subtracting sitting height from leg length, and we still see major differences in multiple types of OI. Even more convincing is a recent study done by groups from McGill and Baylor that specifically measured individual bone lengths in multiple forms of OI at different ages. And we can clearly see decreased bone growth in type 3 and 4 OI in both children and adults, but also somewhat in mild OI. So type 1 OI, we can also see a little bit of reduced bone growth. So overall, we can conclude that OI mutations, particularly those that result in moderate and severe forms of OI, result in alterations in bone development that lead to shortened bone length. So why does any of this matter? I mean, the main morbidity for OI is fracture. So why do we care about height? So one reason is height does matter to some patients, and this has been a touchy subject, especially in the little people community and the achondroplasia community, but there are some patients that are seeking shorter patients that are seeking to ameliorate that difference. But importantly, bone growth affects more than just height. It affects especially spinal development, as well as the development and function of other organ systems. And it can really affect quality of life if the bone growth defect is severe. Growth hormone treatments so far there have been several studies, and they've been really effective based on genotype. So as Dr. Marini has outlined, there are lots of different mechanisms behind different types of OI. And then there have also been recently studies on stem cell therapies trying to ameliorate the bone fragility in OI. And the reason I talk about this is because these have also been variably effective, but studying endochondral development in cartilage tissues actually gives us an opportunity to study the source of progenitors for mature bone. So we're studying cartilage, but we're also studying cells that do eventually turn into mature bone. Now, when we think about short stature, generally the first place we look is the cartilage growth plate. The growth plate is composed of differentiating chondrocytes that are organized into a resting zone, a columnar-like proliferative zone, and then they undergo hypertrophy before finally undergoing either apoptosis and mineralization or transdifferentiation into osteoblasts. And these cartilage growth plates are also surrounded by the perichondrium, which is a fibrocartilage type tissue that really acts as a signaling center and communicates heavily with the developing endochondral growth plate and influences its proliferation, hypertrophy, and development overall. Now, the perichondrium, particularly the tissue area of the perichondrium called the groove of Ranvier, which is kind of in this area here, is also a source of progenitor cells that contribute both to the developing cartilage as well as the developing osteoblast population. Now, to try to move into growth plates in human patients, we have some patients here at UCLA. This patient here is a type 3 22-week growth plate, and this patient here is a type 2-3 19-week growth plate. And while these are on the more severe side of the spectrum, when we look here in the hypertrophic zone, we can see that these mineralization zones that should begin earlier are starting late compared to control, are starting later, indicating a disruption in cell secretion. And in this one, we should be seeing better organized and more columnar-like cells, but clearly most of these cells seem to have lost their way. In an older study of OI growth plates, this group in Italy identified several abnormalities in these tissues, including reduced collagen staining and growth plate disorganization. They also saw scattered mineralization zones and distorted or reduced trabeculae, and this is in multiple different types of OI, as well as ossification of the groove of Ranvier in a severe form of OI. So historically, The OI field has observed cartilage growth plate abnormalities. However, these types of samples, of course, are generally very difficult to procure. So it's not until several years later that the field really began to study this further using mouse models. Now, over the years, so you've already heard of these mouse models from Dr. Lim. Multiple of these mouse models have been shown to have shorter stature, shorter bones, and abnormal growth plates. So the CR-TAP mouse, established at Baylor College of Medicine, is on average both smaller in weight and overall size, and shows abnormal organization of the growth plate zones. And then a study done at the NIH of the G610C mouse, a collagen 1 mutation, as you know, also shows decreased size, decreased bone length, and alterations in the length of the bone growth plate. Our group at UCLA here is using the AGA2 mouse OI mouse model. And this is a mutation in the COL1A1 protein. And these mutations result in a more moderate version of OI, moderate to severe version of OI, as Dr. Lim mentioned. But specifically, they are also much smaller in size. And so when we examine the AGA2 growth plates, we see a significant decrease in the proliferation zone. And another group in Tianjin recently showed that chondrocytes from the OIM mouse model exhibit decreased proliferation in vitro, falling in line with what we are seeing in our model. Now, 2 recent studies conducted by Dr. Lakin and Dr. Rotsuru's lab at the NIH are the first to really delve into the cellular and molecular pathology behind OI growth plate abnormalities. Using the G610C mouse model, they were able to show in vivo reduction of proliferation of chondrocytes in the growth plate, as well as a reduction in the translocation and transdifferentiation of chondrocytes into osteoblasts. Another highlight of these studies was the demonstration of ER stress in hypertrophic chondrocytes of these G610C mice, demonstrated in this transmission electron image showing enlarged ER cisternae. Now, as Dr. Lim had already introduced, in the last decade, ER stress has become a well-established mechanism behind OI molecular pathology. And it occurs in OI when mutations or deletions in type 1 collagen or the hydroxylation and collagen assembly complexes, when these result in protein misfolding, collagen overmodification, and therefore retention of collagen in the ER. This then recruits BIP, which in turn activates the unfolded protein response. Now, a certain level of ER stress is necessary in collagen-expressing cells, but it is exacerbated in OI and could lead to alterations in cell function and apoptosis. When we look at this with the growth plate, Lakin and Otsuru and their lab groups then demonstrated that treating G610C mice with an ER stress inhibitor, or 4-PBA, resulted in improved chondrocyte transdifferentiation into osteoblasts, as well as increased femur lengths and improved trabecular bone formation. Using the AGA2 mouse, our group here at UCLA also demonstrated that treatment with 4-PBA resulted in increased overall mouse size and length, as well as significantly reduced long bone fracture incidence. So with these studies, we can see it is likely that ER stress contributes to the abnormalities in bone development seen in OI. These results introduce some questions. How does a type 1 collagen mutation affect the growth plate? So specifically, where in the growth plate is type 1 collagen expressed? What cells are affected? And how do mutations in type 1 collagen affect growth plate signaling? So to look at this from a tissue-wide perspective, we performed single-cell RNA-seq of chondrocyte growth plate cells from the resting, proliferative, and hypertrophic zone, as well as the surrounding perichondrium. This is the resulting UMAP analysis, as well as a heat map of all the identified clusters. And what we initially learned from this was that within the broad categories of resting, proliferative, or hypertrophic, or perichondrial, we saw a significant amount of heterogeneity in cell types that are generally considered to be essentially the same. So the single-cell RNA sequencing method is probably the best way to reveal this heterogeneity, and it allows us to uncover expression changes that could be hidden by bulk seq methods. With this mouse harboring a type 1 collagen mutation, we wanted to be sure of where collagen 1 is expressed in the growth plate at a protein level. We see high collagen 1 expression mainly in the perichondrial tissues. And this is confirmed by our single cell data where it is co-expressed with PRX1 and other markers of perichondrial cells. Now, this pattern is well established, and generally we don't see collagen 1 expressed in the growth plate chondrocytes at the protein level. And the perichondrium is well known as a signaling center that influences chondrocyte differentiation. So it could be that COL1 mutations are affecting the perichondrium and therefore cartilage growth plate dynamics. However, when we looked at the expression levels in our single cell data, we also see a lower level of expression throughout differentiating chondrocyte tissues of type 1 collagen, tissues that are normally known to mainly express type 2 collagen. And we confirmed this with RNA-scope in differentiating and resting chondrocytes. So how do these COL1 mutations affect growth plate dynamics? Now, in our single cell data, we found significantly increased expression of several differentiation markers, including SOX9. SOX9 is a master regulator of chondrocyte differentiation, and increased SOX9 is generally associated with accelerated chondrocyte differentiation. However, if SOX9 is continuously increased, it will prevent chondrocyte terminal differentiation, and this falls in line with the earlier study showing reduced chondrocyte terminal differentiation in G610C mice. And we also see it here in our hypertrophic terminal cells as increased. When we performed KEGG pathway analysis of growth plate cells, we saw the upregulation of several pathways, including ER stress, which is known as protein processing in the endoplasmic reticulum, but with the most prominent developmental pathway being MAPK signaling. Now, amongst other pathways, MAPK signaling activation is upstream of SOX9 regulation and could explain why we are seeing the increased transcription of SOX9. When we looked at the effect of a COL1 mutation on these perichondrial progenitors, we saw increased expression of several known differentiation markers here in blue, and decreased expression of perichondrial markers here in red. Specifically in osteoblast progenitors, we again saw increased osteoblast differentiation markers such as RUNX2 and alkaline phosphatase, as well as a decrease in PDGFR beta, an indicator of stem cell-like cell behavior. Now, as I mentioned earlier, these perichondrial cells contribute to both the growth plate as well as the maturing osteoblast population. So we believe that the COL1 mutation results in increased progenitor cell differentiation and therefore a depletion of available progenitor cells overall. Now, where we see high levels of type 1 collagen, we should see ER stress. And we looked at unfolded protein response levels in our single cell data and found the upregulation of mainly the PERK pathway in the unfolded protein response in the perichondrium as expected. We also saw the same trends in the chondrocyte growth plate tissues, indicating an increase in ER stress throughout the growth plate. So is what we're seeing in these changes in the growth plate, are they due to altered signaling and communication from the perichondrium, or the low level of COL1A1 expression that we see in chondrocytes? So this is a question we haven't been able to answer quite yet, but it led us to looking at perichondrial to growth plate communication bioinformatically. As mentioned, perichondrial tissues are highly communicative with chondrocytes. So to analyze how type 1 collagen mutations may affect this communication, we performed NicheNet analysis, which uses known ligand receptor nuclear target pathways in an unsupervised analysis and prioritizes them based on strength of activity and differential expression. So in our AGA tissues, we designated perichondrial progenitor cells as senders and growth plate chondrocytes as receiver cells, and found that through this analysis, several pathways may be upregulated from the perichondrium, but most prominently FGF signaling. And this is a causative. FGF signaling is particularly active in the perichondrium. It's known to play major roles in progenitor cell development, And specifically, dysregulation of FGF signaling is strongly associated with chondrodysplasias, especially achondroplasia. So this signaling pathway has not been directly associated with OI before, and it demonstrates our ability to identify novel targets using newer sequencing techniques. So overall, what we've talked about today is that short stature has been a hallmark of OI for several decades, and is largely dependent on the genotype. But only recently have we started to explore molecular pathology. And mutations, we've also learned over the years now that mutations in type 1 collagen and collagen processing affect more than just bone stability and strength. It can also influence, obviously, other extraskeletal tissues, but also overall bone development and the ability of the bone to function as an organ. And the study of bone growth provides insights into bone development, progenitor cell function, as well as cell differentiation. And these studies and other studies that have been done before us have been able to provide targets for future treatments that could not only affect possibly height and cartilage growth, but could also possibly affect bone strength. And with that, I will welcome any questions. Thank you.
Jennifer, thank you. That's, again, very clear and amazing progress in understanding the biology of the bone growth issues in OI. I have a couple of questions for you. The first is whether these biological abnormalities and the clinical abnormalities in OI are manifest throughout the growth phase. In other words, we know that growth isn't linear during childhood. I mean, it's very fast in little kids and then plateaus a bit, and then you've got puberty. Are all those phases affected?
So that's a little hard to answer, because especially in many types of OI, as the patients get older and older, they're start getting different other types of deformities that will affect their height. So then it's difficult to just measure the growth. But overall, yeah, I mean, it seems like, especially in our mouse models, a lot of the biggest effects on growth we don't see right when they're born. We see some weeks later, and then they start getting smaller. Like, we can't tell, they're not born smaller. So it seems like a lot of the growth defects start happening a few weeks into life. But as far as patients are concerned, that I'm not sure about.
Gotcha. Another question that comes up, something we've been trying to figure out here in Oregon, is the usefulness of bone age assessments. As you know, bone age is a radiographic determination frequently used in kids without OI to predict and understand growth and skeletal development. Do you know anything about the use of bone age or how bone age might be affected in OI?
I only know some. And again, it's also very genotype dependent, and it's possible that Dr. Marini could comment on this kind of during our panel later. But I mean, certainly with the way, especially like with hand bone age, with certain genotypes, especially type 3 or 4, we're going to see shorter bones. And so we end up getting a different bone age with those patients. And so it just doesn't end up being, I mean, it's an indicator of growth retardation at that stage. But oh, Joan says bone age and collagen structural defects in generally a year or two behind age cohort. So.
Got it. Okay. Any other questions? Got to get them in quickly in the chat function. Again, Jennifer, thank you very much. Okay, our last talk is by Dr. Charlotte Phillips, who's a professor of biochemistry and child health at the University of Missouri School of Medicine. She's the director of their MD PhD program. And her research has been, for a long time now, directed at the pathogenesis of of OI in both skeletal and non-skeletal tissues. Today, she's going to talk to us about muscle-bone interactions in OI. Charlotte.
I can share apparently. I apologize.
Just need to hit presentation mode now.
Yeah, should get me going there. Thank you so much.
There you go.
Yeah. What I'd like to do first is just thank the organizers for giving me this opportunity, and I will. Thank you. So we're going to begin our journey with osteogenesis imperfecta, and I want to thank everybody who has given such an outstanding introduction, so I can move right along very quickly. I'm going to first talk about peak bone mass, because we all have that, and we all strive to reach it. And then I'm going to talk a little more about the muscle function, how it's integral in bone strength, then how muscle weakness is actually intrinsic or inherent to osteogenesis imperfecta, and then a little bit on approaches using mouse models to target muscle to enhance bone strength. So peak bone mass, literally, we do all have it. And right now, everyone has the potential, and at their age of attainment for peak bone mineral density, which is generally the measure of peak bone mass, that for males is that 20 to 24 years of age, and females 19 to 20 years of age. And when we think about it, only 50 to 85% of the determinant of our peak bone mass is actually attributed to heritable factors. So that means that there are major environmental factors or modifier genes and influences that contribute to peak bone mass. So when we think about that, those are nutrition, muscle loading, and body mass hormonal status. And so when we have suboptimal lifestyles or factors such as reduced nutrition, muscle loading, those factors, in fact, actually don't allow us to reach our peak bone mass. And when that happens, we are at this point where we are more at risk of fracture and osteoporosis as we age. Now, having osteogenesis imperfecta already gives you a disadvantage for reaching peak bone mass. And so this is where I kept thinking about OI is when I realized this, is how much their patients are great with nutrition. Patients are, we don't mess with hormones, but what we don't really, I think it's an unseen area, was muscle loading. And since bone is inherently mechanosensing, it can respond and adapt to the mechanical environment. And so therefore the muscles are very important, because the largest physiological loads bones typically experience are from their muscles, and bone strength is proportional to muscle mass. And so actually, when you think about normal ambulation, like running or jumping, less than 30% of the force transmitted to your femur is actually derived from that ground force stomping. It's actually greater than 70% really comes from muscle contractions. And the other fact that stimulated this area of work was that children who are physically active are known to accrue 10 to 40% more bone, region specific, than inactive children. And I put this figure up to try to emphasize this. If you notice, the red line represents active boys and active girls during their growth period, and you see the yellow line is in sedentary kids, and that this becomes more and more difficult as we age to actually accrue bone. And so this window is so important for our OI kids just as well as normal children. So there was a prospective study of 49 children with OI, and I'm giving the introductions that kind of drove our thinking on this. There was a study that type 1 for 3 children, and they found really strong associations, this is Dr. Engelbart, between muscle strength, ambulation, and the OI severity, with type 1 kids having the best muscle strength, being ambulatory, with the lower severity, and with increasing severity, reduced muscle strength and ambulation. And Taken et al. Evaluated cardiopulmonary function and exercise capacity and muscle strength in a Dutch cohort of OI children with type 1. And what they noticed was children with OI type 1 had reduced muscle strength and exercise tolerance. What they couldn't decide was this a consequences of sedentary lifestyle or inherent muscle pathology? And so when I was coming into this field, thinking about this was a major question that I really wanted us to resolve. And so my lab and others have approached it by looking at mouse models. And what I'm going to do briefly is review 3 mouse models that we've used and others have used to look at muscle function in relation to bone biomechanics. And so the first one I'm listing is Osteogenesis Imperfecta mirroring the OIM model. And in its heterozygote form, it models mild OI type 1. I realize it's not an ideal model, but it has given us a lot of information. And then the homozygous OIM model models a moderately severe type 3 OI. And when the other model, which has already been described, and I thank Dr. Lim for his excellent descriptions of all of these mouse models, and as well as the other, Dr. Zieba and Dr. Marini's explanations of types. So the JRT mouse in the heterozygote has a combined type 4, type 3 OI, and this is with the Ehlers-Danlos syndrome phenotype. So you have the joint laxity component combined, but it's a severe phenotype. And then, of course, the Amish G610C mouse model, which was representing a clinically mild to moderate OI type 1 and 4. So we started in my lab looking at muscle function using in situ contractile generating force. And basically what we were doing was in situ isolating the muscle and stimulating it to contract. And what I would like you to see quickly is with wild type, you stimulate the sciatic nerve, this is a tibialis anterior muscle, the front of the hind limb, and you'll see it go up, and then we hope for the whole 300 millisecond stimulation, it maintains the contraction and then it drops. But I'd like you to know that the mild OIM heterozygote and the mild G610C are both able to make these strong contractions. There's a little bit of decay, but they're able to maintain it for the 300 millisecond. What you do notice in this contraction with the homozygotes, first of all, it can't do a strong contraction, and it can't hold the contraction. It starts to decay over the 300 milliseconds. So we recognize after a small stature components with OI that the homozygous OIM are also the smaller mouse and have smaller muscles. So it's important to normalize this to muscle size. And that's what specific tectonic force allowed us to do, where we normalize the tectonic stimulated strength, the contractile generating force, to the size of the muscle. And what I'm showing you here is the results of, these are for OIM mice. The black is wild type, the hatched is a het, and then the homozygous. And you're looking at soleus, plantaris, gastroc, and TA. And these are in 4-month-old mice, so it's that peak bone mass. And what I want you to notice is that for the homozygous OIM, they are compromised muscle strength, and it's specific. So it takes into, you've normalized it to muscle. So they have weakened muscle inherent, and it's not related to their muscle size. Whereas when we looked at the G610C model, soleus, the plantaris, gastroc, and TA, you'll notice that it's equivalent between the wild type and its wild type littermate and the G610C mouse. Now I'm going to jump to some data that was, I'll summarize first. The homozygous OIM mouse, as I said, models human type 3 OI, so it's severe. And what we know is that it has decreased muscle mass and relative muscle mass, and it also had decreased contractile generating capacity. We just demonstrated that. This is concomitant actually with decreased physical activity levels, which is we're using a local motor assay, which we've done treadmill running, voluntary wheel running, as well as the box. And so we had, as you can see here with the white OIM bar, that the homozygous OIM has reduced physical activity levels, motor activity. This is also concomitant with reduced whole bone femoral biomechanical integrity. They break easier, and also the biomechanical strength of the bone material. compared to its wild type and its heterozygote littermate. This in comparison to the JRT mouse. So the OIM mouse is a severe model. The JRT mouse that we talked about is also a severe OI model, though it's combined with Ehlers-Danlos, it has a Ehlers-Danlos syndrome features. It has decreased muscle mass and has decreased skeletal and diaphragmatic muscle strength. This was done by the groups in Montreal, Dr. Tower, and indicating here the decrease in muscle size. This is also concomitant with decreased physical activity levels, and they were able to demonstrate this through voluntary real running too. And it's also concomitant with their decreased bone femoral integrity and decreased bone biomechanical strength of the bone material. So I kind of think of OI bones as being made of styrofoam versus wood. So the actual material properties of the bone is weaker, as well as the whole bone property relative to their wild type littermates. When we look at the G610C model, which is mild to moderate OI, it has equivalent muscle mass and relative muscle mass. The contractile generating force of the hindlimb muscles were equivalent, as well as the physical activity levels compared to the wild type littermates. So their muscle function is minimally impacted, if at all. However, it has decreased whole bone femoral biomechanical integrity and decreased biomechanical strength of the bone materials as compared to wild type littermates. So at this point, the presence or severity of intrinsic muscle pathology in OI may be mutation specific or severity specific. And at this point, studies were being expanded in clinic after these mouse models were, people were becoming aware of the mouse models. And what they have found is inherent muscle pathology is present in OI patients. Because prior to this, a lot of the assumption was children may be weaker or fatigue easier because they're inactive. And that has been where we sat. But additional studies by the Lutz in Montreal demonstrated that nearly 80%, and this is Dr. Rauch's group as well, nearly 80% of OI type 1 patients with COL1A1 and COL1A2 mutations have muscle force deficits. And compromised muscle function is more severe in the more severe phenotypes or OI type 3 patients versus the OI type 1 patients. So, but even with this with decreased muscle strength, we still hypothesized that if we could improve muscle strength, we may be also to have an indirect improvement of bone strength. And part of this is driven by what we know about other mouse models and other human musculoskeletal issues. We know that loss of function mutations in myostatin, which is a negative regulator of muscle growth, increases musculature in humans and animals with concomitant increases in bone size and strength. Myostatin is a negative regulator of, of muscle size and strength. And in a heterozygotic form, it actually maintains very strong, good muscle function. And so when you reduce myostatin, you actually increase muscle mass as well as bone mass. So we had, our working hypothesis was that while OI bone material is biomechanically weaker, it can respond to increased muscle load by altering bone geometry and architecture to generate inherently stronger bone. Basically, we want to go from thin styrofoam to thick styrofoam, and that would reduce fracture. And that was our whole overwhelming simple hypothesis. So to do this, we first initiated a genetic approach. So we generated mild OI offspring, which were also myostatin deficient. Here's a breeding strategy for the OIM mouse, where we were trying to generate heterozygote OIM with heterozygote myostatin deficient, as well as the G610C mouse, which was heterozygote for the G610C mutation and myostatin deficiency. And what we found was both myostatin and OIM, myostatin OIM and myostatin G610C mice had increased muscle mass relative to their OIM, PET, and G610C littermates. This is kind of very exciting. When we saw their weights going up, we were getting very excited. The when we looked further, the myostatin OIM and the myostatin G610C mice both had improved trabecular bone architecture relative to their OIM and G610C littermates. And this has been emphasized here. Here's the myostatin OIM compared to its OIM littermate, looking at bone volume over total volume. And I think it's easy to see the increase, as well as with the myostatin G610C. With the G610C, you see a significant increase in the trabecular bone volume. But the question is, does this improve bone biomechanics if we can get more bone? And so congenic myostatin deficiency significantly improved our Het OIM femoral biomechanical strength. And outlined here, I have shown you energy to failure. This is done by torsional loading to failure, and you're looking at wild type, myostatin Het, OIM Het, and here is myostatin OIM Het. And I think it's clear to see that we have had a significant increase in the energy to failure, or the amount of energy it takes to break the femur. When the OIM mouse is both heterozygote and has myostatin deficiency. Whereas in the G610C model, congenic myostatin deficiency did not improve the cortical bone properties or the biomechanical properties. So what you're looking at here is, here's the G610C, and here's the G610C myostatin Het. So at this point, we are looking at the genetic model. We're not going to make like people. So our thoughts were, is there a way of testing a therapeutic approach to decreasing myostatin so that this might be an approach potentially for patients in the future? So we took a pharmacologic approach to reduce myostatin by using an anti-myostatin antibody. This was provided to us by Regeneron Pharmaceuticals. And myostatin is a circulating molecule, and by using an antibody that binds up myostatin, we're able to reduce circulating serum levels and then induce a deficiency of myostatin. So that was our approach. We started at 5 weeks of age for wild type OM and G610C, and treated them all the way to 16 weeks of age, because 4 months of age or 16 weeks is peak bone mass in the C57 background mice. So wild type littermate trabecular bone parameters were more responsive to anti-myostatin treatment than OIM and G610C. And what I would like to do is review the data, or some of the data that I'm able to show you in the limited time. This is the homozygous OIM. What we're looking at, male wild types and male OIM homozygotes. Black is control antibody, and white circles are myostatin. We're looking at bone volume, and as you can easily see, the wild type have significantly increased bone volume with anti-myostatin treatment, which was not significant or does not appear to have happened in the homozygous OIM. Bone volume to total volume was also increased in the wild type. When we go to the G610C model, we see also increased bone volume in the wild type littermate males, as well as the G610C was more responsive to the anti-myostatin for the bone volume, though it didn't reach significance in bone volume to trabecular bone. So this is at the level of increasing our bone. What about biomechanics? Basically, anti-myostatin antibodies increase the work to failure for male wild type femurs, as well as maximum load, yield load, stiffness, and work to failure in male homozygous OIM. So the biomechanical integrity of these bones was improved by anti-myostatin therapy. Again, this is maximum load. These values come from 3-point bend. And they're in the femurs. This is wild type male control antibody, wild type male anti-myostatin, OIM, control antibody, anti-myostatin antibody. And as you can see, for all cases, for all genotypes, the anti-myostatin antibody therapy improved bone biomechanics in the OIM homozygous. Now, however, in the G610C model, there was the work to failure in response to the myostatin antibody did not reach significance in the G610C or the wild type glutamate femurs. So at this point, I'd like to summarize. Genetic myostatin deficiency can improve the mild heterozygote OIM and heterozygote G610C muscle mass and femoral trabecular bone properties, and significantly improve the heterozygote OIM femoral biomechanical strength. Postnatal pharmacological inhibition of myostatin by monoclonal anti-myostatin antibody treatment for 5 to 16 weeks of age improved some bone parameters in both G610C and the severe OIM homozygous mice. However, bone improvements were not as robust as those achieved with genetic myostatin deficiency, suggesting prenatal and early life myostatin inhibition may be critical for maximum efficacy. And increasing muscle mass and strength via pharmacologic and increased physical activity, targeted resistance training is the model that I would propose, continues to be a valuable therapeutic target to enhance overall skeletal strength. But further studies are needed to identify the most effective and safe approaches, as well as to identify those genetic variants that are most responsive and the severities that are most responsive. And finally, I just like to really thank the wonderful group of graduate students and undergrads over the time who have really helped with this project. I couldn't show all their data, especially when you add the swimming mice, treadmilling mice, and voluntary wheel running mice. There was a lot of time invested in these studies. I'll take questions. Thank you.
Charlotte, thank you. Obviously, the bone muscle interface is critical for OI. I have a question about that for you. There's been a lot of interest in myokines and how they might mediate the crosstalk. Do you know of any data about whether OI muscles are different in terms of their production of myokines that might be important?
I know that we've measured the myokines in the OIM mouse, and they were, in our mice, they were reduced inherently. So inhibiting them might have part of the, I'm not sorry, they weren't reduced, they were elevated. So in both of our models, the G610C and the homozygous OIM, they were already a little bit elevated, myostatin was. As far as irisin, I don't know that much about that. I know that that is an area that recent work has been being done from the muscle too as another target. But yes, so I think it's real important that we have to know the levels in patients, because I think part of it is like, even with activity levels, you change your myostatin levels if you're going to use that as one of your targets. Yeah. So, and then there's inflammatory markers which could impact it as well.
Yeah,
so I don't know that I'm really answering your question that well.
well, I bet there's not a whole lot of information yet. Probably a fertile area to pursue.
And actually, we found like we have a mitochondrial dysfunction, which models to some extent what happens in Bethlehem's myopathy and Ehrlich's myopathy. So perhaps at least with the OIM model, we might need to think of it as a potential muscular dystrophy related kind of phenotype too. And so how does that reflect with patients too? There's some suggestion we should be looking at that collagenopathy in light of some of those types of therapies.
Yep. Got a question in the chat, which is, do you think there's an optimum enhancement of muscle mass that could improve bone without increasing fracture propensity?
Absolutely. I do think so. I think one of the studies by Berman in their group with the OIM mouse, they actually put sensor at the base of the muscle where it's next to the bone so that they could measure, one of the questions is, can an OI bone get the same contractile signal, because it's got to go through the muscle and the tendon. And since we have more lax tendon, perhaps the signal dissipates before it ever got to the bone. And in Berman's study, Dr. Joseph Wallace's group, they found that the OIM mice contraction doesn't send enough signal. It's lower than wild type, so your bone doesn't get as strong a signal from the contraction. However, it does get a contraction signal that should be high enough to stimulate bone formation in its maximum form. And so their hypothesis is if we can increase the contractility a little bit more because of the tendon and the signal transduction, we can elicit the response. But that's where I think the resistance training in a physical therapy setting where someone is watching your tendons, would be the way to learn to gauge it for the patient, because you want it to be high enough to be sure to elicit the signal. And I think it can be done based on the mouse models.
Okay. Well, let me encourage people to add more questions to the chat if they have them, but I'm going to open it up a little bit to questions that came in that we weren't able to get to. So let me start with this first one for Joan and any of the other presenters that might want to comment. Joan, this question is interesting. Should everyone with OI, and for that matter, their providers, know what their genotype is?
Oh, my impulse is to say yes. It's I would even go further, frankly, that and this isn't, I think everyone should know what their primary mutation is, but that we as a field stop when we find a plausible causative mutation. Now we do panels, but we stop at that point. And I think as we go further into the genetic era, we'll be doing more, exome sequencing and looking, of course, at modifying factors and other things. So if you don't know your primary mutation, must you know it? Well, I think it's useful.
Yeah. Other comments? Okay, question for Dr. Lim, and this gets is sort of a translational question from a chat question by Phil Calkin, who wonders how close we are to genetic therapies for OI. And my question to you, Jason, is are animal models useful at present to understand potential genetic therapies?
That's a great question. I'm not sure I'm particularly the best person to answer, and I'd be happy to listen to other folks chiming in. And certainly it's a useful model to explore different venues for therapies, right? And certainly that's been demonstrated by all of these prior studies showing the efficacy of anti-sclerostin antibodies, bisphosphonates, combinatorial therapies. One of the things that I think being trained as a bone biologist, I think is really interesting is, for instance, in the various severe models where we don't necessarily have the same type of effect from the existing therapies, obviously we can use this opportunity to allow for more optimization in different cocktails of therapies. And that's certainly one way we can still improve. In terms of genetically modifying the mice, I suppose, would you be able to, for instance, I guess if you're alluding to potentially stem cell therapies or the ability to use genetically modifying factors to be able to rescue the phenotypes postnatally, yes, absolutely. exactly which approach, I think really is, again, going back to Dr. Marini's comment, going to depend on the genotype. And perhaps, yes, this is the best opportunity to exploit the best use of these various animal models. And again, I think both, in that sense, both conditional knockout approaches and knock-in approaches where we have the animals display more closely the human OI phenotypes, both skeletal and extraskeletal, that definitely may be an opportunity, not just to get at the mechanism, but also more getting at the translational. I'm not sure if that really answered your question, but yes, I think they are definitely useful, but we definitely have not used them to their full potential.
Yeah. Others want to comment on the issue of genetic therapies for OI? How close are we?
Oh, I think there's still so much off target that we would be hard to cure a mouse at this moment.
Yeah.
I think it's even greater than that from just those who have worked with stem cells, identifying even the right mesenchymal stem cell that would actually be incorporated. Because I feel like there's been a lot of attempts at just even doing autologous like transplantation that we haven't figured out how to do in mice, where they would take, like, they're congenic mice and you give it the wild type.
Right.
And it just hasn't worked yet. And so I think we're missing some key factors of research there before you can start giving back corrected one, just based on history.
Yep. Another question for Joan, and this is, how should we define or think about type 2 OI? We usually think about type 2 as being perinatally or intrauterine lethal.
Right.
But if someone lives beyond that time, are they automatically type 3, or how do we sort that out?
That's a tough question. I think it's influenced by a couple of things. One is that we already know that we see tremendous variability, especially structural changes in the alpha-1 chain, can have outcomes ranging from what are called 2 to 3 to 4. Are they the same? Are they changed by modifying factors? I don't think there's really a bright line between any of the structural types. There's a preponderance and there's agreement as to, what's a 4 and not a 3. And in general, what's a 3 and not a 2. Perhaps lethality is the brightest of lines. But I do think that there are a small group, I don't know what it's just an observation, so now I'm getting phenotypic horrors, but there are a small group of super severe survivors, in that they live beyond the perinatal period and often even the first decade of life, and they are so small, and of course they have tremendous relative macrocephaly, and on radiographs the bones look so poorly formed, and one can't help but think that they could have been type 2s. I think that's part of the trouble with even the dividing lines between the collagen types.
Yeah. Well, this gets into the issue of phenotypic variability, which is a huge issue in this field. I hear a lot about that in terms of the skeletal disease, but Dr. Zieba and Phillips, do we see the same sort of variability in the growth pattern and the muscle dysfunction? And does the variability in these other phenotypes correlate with the variability in the skeletal phenotype?
Oddly enough, interestingly, which I don't think anybody has an answer for, particularly in the AGA2 mouse, which again is just, it's on a isogenic background. They all have the same mutation. And actually we get some mice that are extremely severely small and therefore extremely severely fragile, even within the same litter, compared to other same genotyped litter mates. We have no idea why that variability is happening. So even within same genetic background. So.
Clinically, you see the growth variability. When we did the curves using children we'd seen from toddler to 18, looking at 100 patients. So this is not cross-sectional, this is longitudinal data. And there's a sizable amount of variation for the types. A sizable amount, even, there are type 4s who are within the normal growth curve. That's a, those curves are in percentiles for a reason. There's quite a bit of variability.
That speaks to modifier gene.
Yes, the next decade.
Yes.
Right. This is a tough question for everyone. And it is a general question to all the speakers. Take it any way you want. Can anyone define what are the key features or phenotypes of OI? I guess we're getting at, is this a skeletal disease or a non-skeletal disease? What's most important? I'm really curious how you're going to answer.
I'm willing to take a stab at this. I think it is a generalized connective tissue disorder whose primary manifestation is in the skeleton. And that we've always wondered about the short stature. Why were we getting this in an osteodystrophy? I'm not at all philosophically surprised to see the cartilage defects, then it makes sense as an osteochondrodystrophy. That was one of the big lessons we learned from the 3-hydroxylation groups. Fractures, bone fragility, bone weakness, deformity, some extent of growth deficiency. There are typical features across many types in the bone, mostly high turnover, hypercellularity, some degree of ER stress, the paradox of hypermineralization in the tissue versus a low DEXA score. But it is a generalized connective tissue disorder. The lung dysfunction is not simply from thoracic shape or scoliosis, and there are other non-skeletal tissues involved, and they wind up being the major causes of mortality.
Okay, we are just about at the top of the hour. I want to thank all the presenters very much for outstanding discussions. And the last thing we're going to do is go back to Michael for some opportunities in the future. Michael, do you want to final comment?
Thank you so much, Dr. Orwoll. Again, I want to echo what you just said, and I want to thank all of our speakers here today. These conversations are very important, and we're so happy to have you all with us here this evening. Just two quick things I want to say is, one is, if you are interested in more virtual presentations around rare bone disease topics and beyond just OI, please, we encourage you to look at the Rare Bone Disease Alliance Tele-Echo program. This is a monthly essentially a virtual webinar series with each month on a different rare bone topic. I'm going to put the link to the website for that in the chat right now, if anyone is interested, and happy to answer questions on that later. Also, I want to let everyone know that so the OI Foundation is hosting a OI Clinic and Bone Health Clinic Town Hall meeting on June 9th. This will actually be both in person and virtual. This will be in Arlington, Virginia, right outside of Washington, D.C. And we hope that anyone who's interested, please reach out to our health educator, Kenna Coleman, who is running some of the programming and organizing for that. I'm going to put her email in the chat as well. And so just thank you all so much. And we hope to hear from you all soon.
Once again, thank you all for participating. And again, especially to the presenters.
Good evening.
Good evening, good morning, good afternoon, wherever you are.
That's
Yeah.
right, morning in Europe.
Absolutely. Great. Thank
Go
you
to
all so
bed.
much.
Bye-bye.
Thank you.